My name is Marvin Malek. I'm one of the preceptors in the Northern New England Health Policy Internship Program. And today I'm going to begin a discussion of cost control strategies. And as you've heard from Dr. Dolkart, very high costs in the U.S. healthcare system are a central problem and really are responsible for tremendous difficulties with access to care. They're straining the budget of businesses, and they're a big burden on government, leading to higher taxes. And I just want to say this is not just at the federal level, but also for businesses. So insurance companies have to raise their premium, making their product less affordable. And when I talked about the government, I didn't just mean the federal government, also state and municipal governments. And if you talk to local officials who are in your state government, wherever you are, or municipal, they'll tell you what a huge strain on budgets, providing health benefits for their employees, how expensive that is in the United States. And by the way, another thing you should keep in mind, just to say a little more on state and municipal government, is that if we did have a national single payer program, then if it were administered in regions or in the state, then there would obviously have to provide funding through taxation at the state level. But basically, municipal government, which is really struggles with these costs, they would probably be off the hook. So if you're involved with your local politics in your city or town, something to bring up that you're struggling with healthcare costs and you have no ability to win this battle. You have no levers to control costs other than giving your employees crappier coverage. So this is so I think you can begin to make an effective argument for health reform, even at the municipal level, where as far as I can see, there's few levers to actually do much useful other than, advocacy for bigger reform. And then, of course, on the left over here, patients are really struggling to pay. And Dr. Dolkart earlier today showed you some of the ways that there's GoFundMe going on or people just give up trying to get access to care at all. So you've seen about how much higher our costs are compared to the international average of developed countries. And if you look at this chart, by the way, just to highlight it, the countries at the top, all of them really up till France, all of them do not have single payer systems. They spend a lot less than we do anyway. And in your international health presentations, you can describe why they do better than us, but not as well as the countries on the bottom, especially Italy, UK, Ireland, Canada, and Sweden, which do have and France has a modified single payer system. So you can see even right here that the countries with single payer systems manage to provide healthcare for their populations at lower cost. And when you look at outcomes, we're not exactly doing well, and there's not much of a correlation between this level of spending. The countries that spend less and have single payer systems have generally good outcomes. So let me just go on from this because I'm going to get to this in a different way. So 4.5 trillion, and here's the same chart again. 4.5 trillion, 4.7 trillion in 2023, 12,555 per person. It's crazy. Number one, expenditure. We're actually now we're approaching 20% of GDP, more than any other country. This graph is really important. You've probably seen it before. This may be this is definitely rather in the top 5 important slides. This is a good one to remember, a good one to use at your presentations. And what's going on in this slide is starting around 1980, which is the left side of the graph, the U.S. was high end in 1980, the US was at the high end of spending among the developed countries. As time went by, and this is the beginning of the Reagan era, which is, from my view, has lasted, most of the subsequent 40 years. We used a variety of strategies to modify our healthcare system, and the other countries did as well. And those clumped together countries that are all the various colored lines, uh, also were providing healthcare for their populations, and so is the US. But what you see is that in the US, we deviated to an ever greater degree. And the deviation continues unabated. That our overall costs rise at a faster rate than the other developed countries. Going back to the other developed countries in this graph, notice that their slope is not zero either. Their costs are increasing too. And when they look at this graph, they know about the United States. Everybody knows about the United States. We're talked about a lot abroad. And they look at that graph and they don't say to themselves, the US, we're doing so much better. Look, it could be so much worse. We could be spending the way they do in the US. But we're just viewed as a bizarre outlier by all the other countries with a fairly dysfunctional healthcare system where people can't get care while at the same time we're spending so much more than everybody else. But it's actually not reassuring to them because they all know the US is a bizarre outlier. But to them, that positive slope, the fact that their costs are increasing, is a problem, which they're all facing. And when you do your international health presentations, I think it's going to be important for you to look at that and find out what strategies. You'll notice the other countries are working on it and also frustrated because it's not easy. And some of what they're dealing with has to simply do with demographics. Their populations are aging and older people aren't contributing money into the healthcare system if they're no longer working. And at the same time, they have more medical needs. So that's a big part of it, but there's also new technology. Anyway, so they're all facing it. And when you do your presentations, you'll learn more. My task over this week is to try to begin to understand I'll understand why we're deviating and what the features are that make us a deviant. By the way, when you do your international health presentations, please bring to the discussion what the biggest complaints in that country seem to be. What things people in that country find inadequate about their healthcare. That's always useful. Healthcare systems are huge, and it's 20% of our economy, but it's 10 or 11 or 12 in a lot of those economies. And when you have such a huge a huge part of your economy, there are going to inevitably be problems. So I'm going to move this. So drug costs in the US are also very extremely high. I don't even think you can see the right side of this graph, but anyway, the US is top of the pack for drug spending, and that's something we're going to cover later in the internship. If I can get past the slide, I'll be happy. Okay, here we go. So the rise increments in healthcare spending are outstripping the pretty much all other costs. Interesting thing is college tuition has really been an issue. Some part of that is healthcare costs, but there's other factors there. But most of the other items are not inflating at the rate that healthcare is. Sorry, I just missed something there. Yeah, and deregulation of energy, I think, occurred there. Anyway, for what it is. And here is the general consumer price index, the blue line, and medical inflation is the green line. So if your patients tell you that things have been gradually getting worse, they're right. They are spending a large portion of their household income on, or as an aggregate, we're spending a larger portion of our household income on medical care. You already saw this. Dr. Dolkar talked about bankruptcy. And this is an important one to understand, that healthcare costs have been rising, and the cost that people pay out of pocket to get their healthcare has been rising. We talked about that last week. We talked about the cost of premiums rising, and the proportion of the premiums paid by the workers has been going up. That's the green line here. And the blue line is showing family premiums. And the fact that that's rising at a faster rate than the green line is the single worker. So if you work somewhere and you get single person coverage just for you, your employer will cover some percentage. But what you've been seeing is that since 2010, in this last decade, if you are trying to get your spouse and your kids covered, that coverage has been getting increasingly costly at a higher rate than if you just want coverage for yourself. So this is one of the strategies that employers are using to control their healthcare costs. That if you're going to try to insure your kids and your spouse through their plan, you're going to increasingly pay more and more. That's going to get really expensive. And then the top line, the brownish orange line there, that one is out-of-pocket costs in the form of co-pays and deductibles. In other words, the premium paid you pay just to get the policy. But once you have the policy, you still get to pay more. And a deductible is the first several hundred or $1,000, and it's getting to be worth $1,000 or $2,000 is the average for a deductible. And then even when you're done paying everything for those first $2,000, then you have the privilege of paying co-pays at each visit. Some portion of it will devolve to you paying. There's a very ironic, endearing term for that, which is cost sharing. That you get to share in the cost, so the insurance company doesn't have to be the only one paying, because they would get lonely that way. Anyway, so you get to share in the cost, and y'all can do it. So anyway, but you see the concept here is that the amount of money in the form of that you're paying on in deductibles and co-pays has been rising faster than the premiums, than what you pay for premiums. So that's the way this has been kind of devolving over the last decade, and really more. Now, the other motive for high deductibles, why insurance companies like high deductibles more than high premiums, is that if you actually have a choice of policies, the policy with the high deductible is going to be cheaper. And they're going to pay, and the insurance company itself is going to pay less. So if the workers had a choice, if they're very sick, they're not going to want that policy. And you remember how expensive the 10% of the population who are sick are. So if all those people tend to try to get better coverage and avoid the high deductible plan, then the high deductible plan is going to be cheaper. The premiums will go down, and they'll do really well competing in the market. So here's the concept that poor quality coverage tends to win out in the market in competition. Because if the sick people are 100% going to go to good coverage, then those two bar graphs on the right end of that bar graph that showed they had all the expensive people, that they're going to drive the cost of the really good quality coverage up. And if you started out with 25 or 30% of the people in the high deductible group, then the more and more of the healthier people are going to go over to the high deductible group, because all the sickies are over in the good coverage plans. So that really constitutes a real problem. Finally, in this graph, you can see the overall inflation rate, which is lower, and as our worker earnings. And I guess I interpreted this wrong. The orange one is worker earnings. I misread that. I'm sorry. So, but the point I made, incorrectly assuming that was a line, what I said actually was true, that if you want to insure your kids and your family, that's been getting more expensive at a higher rate than your portion of the premium. I'm sorry, I misinterpreted that. And so that all this healthcare inflation is a lot faster than worker earnings or overall inflation. So here Ken talked about the tremendous suffering that cancer patients, are faced with. Deductibles, copays, letters coming in telling them they're not going to cover stuff. It's completely unacceptable. But that's what happens in the U.S. in the fundraising sites. I think Ken talked a lot about bankruptcy, so I won't continue that. Let's see what this one was. Yeah, so you've talked about the outlays of healthcare. We're going to get to that in a few days, and Ken talked about it as well, but not today. So there's many reasons for higher costs in the U.S. My analysis, and I actually just read an article that was pretty close to this, more elective procedures. At the very most, that's 10% of the excess cost. Higher prices, higher administrative costs, higher prices for drugs and almost everything else that get bought, ranging from hospital beds to drugs and everything, higher malpractice costs. And I want to make a point about malpractice costs. The total direct cost of the malpractice system is 1% of overall healthcare spending. Many physicians worry about getting sued, and they'll say that they order tests they really know aren't necessary because of that. Every other developed country spends way less than we do on the malpractice system. So for two reasons, I would like you to advocate to lower malpractice costs as much as possible, notwithstanding the fact that they're not that much. One is that practicing medicine is extremely difficult, with the exception of a few specialties, which are not as difficult. Radiation oncology is on that list. That's always my albatross. But almost every other specialty, you're making difficult decisions based on what information you can get, and there's tremendous amount of uncertainty in every specialty. Medicine is difficult. You're not getting to an easy profession. I worry about making a medical mistake every day. I worry about it, and I go over things twice. The software doesn't help as much as it could. That may get better during your lives, but I knew right from the start it wasn't going to in my life. But anyway, maybe it will for you. But so far it hasn't helped to prevent errors. And so physicians make errors. Sometimes they make a difference, and it would technically qualify for a malpractice suit. But I would encourage you to push for reform. First of all, I have the principle that every single percent or half percent you can knock off health costs, take it. Take it. Because every percent of these battles, yeah, we spend way more on administrative costs, but every percent of that to fight against will be a fight. Getting to single payer health reform will be a fight. All these are going to be difficult battles. So every little victory you could win, you should take it. And I don't want these victories myself. My opinion is that not by increasing deductibles and co-pays and oppressing patients and making healthcare unavailable, inaccessible. So if you can find a way to reduce costs that doesn't harm patients, and trust me, that's one of them. It doesn't help me to provide better care and the reason I'm going over things multiple times is not because I could get sued, but because I don't want to come to work tomorrow knowing I harmed someone because I made an error. I don't want that. So I'm careful and I get out of work late. It's just the way it is. So I think when you're advocating with doctors, we put it on your list. Tell them you support malpractice reform, and it'll lead to a little bit of cost control and help us just feeling like there's not a bunch of lawyers on our, looking down our shoulder and, make burdening all of us a little more. And it also adds gratuitous costs. About a third of the costs within malpractice suit are awards. The rest of it is court costs, lawyer costs. It's diverted, defense lawyer, plaintiff lawyer. So it's not even efficient, within that 1%. Anyway, I'll get off my preachy thing. So let's say you wanted to save money on oranges. Um, let's say the oranges cost 50 cents where you bought them, and you buy 6 of them. So that leads to $3 of spending. And by the way, if somebody could put in the chat why this didn't do word wrap and why these words are broken up, I would really appreciate it. If there's something I can do, or if you know why this happened, because I don't. Anyway, but I want all of you to tell me if you wanted to lower your spending on oranges, how could you go about doing that?
Probably buy less oranges.
Okay, reduce the volume. Number one, you've only got 5 people in the family. You only really want people to eat one orange in a meal, so the extra orange is unnecessary. Or maybe you actually have 6 people in your family, but your budget's strapped, so you're going to buy fewer oranges. So that's a great answer. But there's other ideas. So what other ideas are available?
You
I
could
would
get
say
together with, oh, go ahead.
I was gonna say like actually opposite. Like examine the trends in like orange prices, and if you see that it's like kind of increasing, you might want to buy in bulk so you can save later. But
Okay. So what you're saying is you've come up with one strategy to lower the price. So was it Nehemiah who spoke up first about the volume? He wanted to
Yes.
reduce. So Nehemiah hit volume, and now you're trying to find a way to hit on price. So that's good. So any other ideas?
You could try to
Um,
haggle.
Sorry.
Sorry. I said you could try to haggle with the person selling the oranges, try to talk them down.
Great. Okay. So you can negotiate. So that's another way. So you're not looking for a volume discount. You're just going to negotiate, and that's fine. Um, but really, okay. And so what you're going for is the price. Nehemiah went for volume, and you're a second strategy to go for price. And go ahead, try to come up with maybe one more, or you don't have to if you don't want, if somebody has any other ideas.
I mean, I was just gonna say you could probably just not buy any oranges.
Okay, so you could just opt out of the whole thing, and that'll get you to pay less.
One thing I would say would be like quality of oranges. If there is a trade-off between like a good quality orange costing some amount versus like a little bit less quality with decent price, then probably that's the idea.
Okay, so that's good. So you're gonna go for price also at the by sacrificing quality a little bit. So we have 3 that have come up with price related strategies, and one Nehemiah, and I don't know who the person was that wanted to buy none, but anyway, you could forego getting it all together. And so that's kind of a volume strategy. You're going to get a volume of 0, and Nehemiah sounded like he was going to reduce it a little less, maybe to 4 or 5. Anyway, so
And
you got it.
Dr. Malek and Gabriella said suggested price matching at a different store and maybe switching to like Clementines. And she said that you can get like more for your buck that way as a suggestion.
Again, you're going to not reduce quality, but reduce the style or something else, and in a strategy to go for price. So that person's going for price too. By the way, in microeconomic terms, you can call that a substitute if it's a clementine as opposed to a larger orange. But anyway, either way, you're reducing the price and allowing you to pay less. So you're controlling costs this way. So you've done great. So that's fabulous. Every answer is right. And one thing I want you to keep in mind though is that you had, I think your ideas about price control had more variety than the ideas about volume control. Or just leave it that way. But because I think it's almost inherent in the situation that price. I think in healthcare, price has more promise as well. But we'll get to that in a minute because there's a famous researcher that weighed on this. So how could we save on interventional radiology, cardiology rather? Coronary, the amount of money we spend in the United States just doing coronary interventions, either bypass or stenting, PCA. Think back on the oranges.
This might be a little earlier, but like perhaps reducing the need to do it in the first place. So solving heart disease earlier in life with like education or like healthy practices through like public health.
Okay, so you're going to go after volume in a proactive, public healthy, long-term kind of way. And that's good.
I
Let me
have a
just add to that though, on the day when a patient's having a heart attack, that has your strategy is not relevant to that day, but the longer term prevention might have been really helpful. Every single payer system and organized healthcare systems includes a higher proportion of their budget on public health and preventive medicine as compared to the United States. So they would agree with you. Keep going, and you can lean on the oranges if you want to.
I don't think this is as necessarily as proactive. But I know some hospitals run into the issue where they don't spend as much money on modern equipment because it's expensive. And so they'll have equipment that is older or doesn't work as well or isn't as modern for the issues. So that could be a way that costs have been reduced by just not having as up-to-date equipment.
Yeah, sacrifice quality, but do the same number of procedures with worse quality, or jeopardize quality if the equipment isn't good or something like that. Not the kind of solution that people would publicize, or even want to do. They would want to do that what they feel is best. I have to say that, let me just say, I already said I was biased in favor of what Himmelstein's going to say, but I just don't know very many physicians who go to work wanting to do something other than a really good job. And so having to bribe doctors to do better quality care just seems so stupid. Nobody will be happy working with inferior equipment in an interventional cardiology lab. They won't. And they'll have higher, they'll add to their woes by not only having poor equipment, but they'll probably have more turnover of physicians who won't, if it's truly inferior, they won't want to work there. But anyway, you're saying, but let's say it more positively. Maybe you could get a better deal on how much you're paying for the equipment. How about that? To go after price, go after the price of the equipment through some other way to buy it. And when you're at the hospital, you probably saw a little bit of that. They can't get the discounts that larger facilities get because he's a dinky little independent hospital. Anyway, any other ideas? Think back on the oranges.
You could find labor that's not as expensive, so maybe you don't need the best cardiologist in the world. Maybe a resident is fine.
Okay, so you're also going after price and maybe sacrificing quality a little bit. Or in a more positive light, you could say it's more efficient maybe to get it done the other way. Other ideas?
And I feel sorry.
Oh, I was gonna say like an extreme volume example is just close down the interventional cardiology lab. It's too expensive for you. Shove them to another hospital.
Well, that's fine, but yeah, you can do that, and that is important. That's an important point because there are in many, not all, but in some areas of medicine, highly technical, difficult, uncommon, but very invasive things. Many procedures are shown to have better outcomes at highly specialized centers. as opposed, so complicated cancer surgery or something like that, it may be better not to go to Bryan Hospital. It may be better to go to a tertiary care center. And anyway, so you could regionalize things and maybe it'll be more efficient, and and then the smaller hospital that close down the service will have a whole part of their infrastructure they no longer have to pay for and support. That's true, and in a single payer system, that's a struggle. In our system, it's even more complicated because let's say the population of a certain area is declining more, there's fewer and fewer people there, as is the case in many rural areas. How long do you keep a hospital open that's not doing much business? So in a single payer system, that would be a public discussion and difficult one. In our system, a lot of it gets decided by what profit related things that are sort of unrelated, but there is an effort to do that when there's an area is overbedded. What's more common is highly reimbursed procedures being offered in too many places, like in two hospitals in an urban area that are right across the street from each other, both offering highly technical services that are duplicative and forcing them to keep infrastructure going that's expensive to run. And you could probably close one of those, get the other one bolstered for a little more volume, and save a whole lot of money. But that's profitable, so that it doesn't happen in our system. What if you were the insurance company, what could you do to lower the interventional cardiology costs?
Oh, I was just gonna add, not from the insurance company's point of view, but I think from in the hospital, the book, the way they save money on the interventional cardiologist for so long was just only having one, and having them work like every day of the week. So I think that's one way you see hospitals saving money for specialized care like that.
Exactly. I'm going to pick up on what you just said. So MRI, the charge for an MRI has been so high in the United States, leading to a proliferation of MRI scanners where they're not needed. And there's a lot of training involved to get the staff going. So it's only in the United States that MRIs for many years were only booked from like 9 to 4. And in other countries, they tend to run, more of the day so that they could actually make use of the technology they had. So yeah, don't, keep people operating more of the day, and that's a potential way to save money.
Another way for the insurance company to save money would be to increase the deductibles or the employer contributions.
Okay, how about denying the procedure entirely? Deny coverage.
You could
Okay, anyway, it's a
also,
volume. So the concept is that some of your strategies have divided into ones that are going to reduce volume and others that are going to reduce price. So Nehemiah brought up the idea of reducing the cost of the procedure by running more of the day. Am I understanding that correctly? That you created a more efficient service by maximizing the use of what equipment you have. So that's going to reduce the cost. In the United States, that may not reduce the charge that the patient sees. So the charge is what's in the bill. The cost is what it actually costs to provide the service. Always keep those separate in your mind. That when somebody talks about healthcare costs, are they talking about charges? Patients talk about charges because that's what they see and that's what they face. But hospitals, they know what they're charging. They could change that, and they know what a unit is costing to run. So keep that in your mind. Is this a charge or is it a cost? So, but anyway, what I wanted to sort of say is that in some cases, some of your proposals are reducing the cost or the price for providing the service, and other strategies could reduce volume. For this one, you didn't say much about volume, but maybe some coronary angiographies are not necessary, medically necessary. And that's another potential strategy, is to look at volume. And I think what you've been finding, though, is that when you go at price, there are more ways to do it. And but anyway, that's the concept, is that for any medical service. So can I move this thing? So this is Uwe Reinhardt, who just disappeared. And so Shivani's going to get into this slide, so I'm not going to go on with it. But that guy who transiently appeared on your slide, Uwe Reinhardt, did what in the United States is a landmark study in 2003. He looked at, so you guys talked about, came up with strategies, and all of them were reasonable strategies, every one of them that you mentioned about the cardiology lab, and for that matter, for the oranges. And those are all theories, those are ideas, but you could then study the ideas and see which one actually works. In this case, what Reinhardt did was he looked at the number of different procedures that are done in other countries. Say, okay, how many coronary angiographies are done in Germany per capita, age adjusted? Okay, so how many? And what's the price, and then what's the total cost? And what he found was, in overall, 90% of the excessive costs in the US are due to higher prices rather than higher volume of services. So in other words, we do a somewhat higher number of coronary angiographies in the United States, but we charge a whole lot more. The study was confirmed in 2019 by Gerald Freeman, who's going to be talking to you later in the internship. Did a big study and found the exact same thing that Reinhardt had done 16 years earlier. So does this finding that suggests that you should go after costs or prices rather than the number of procedures you're doing? So in other words, this is beginning to get empiric and proven. Okay, so in other words, if you have an idea for a drug that seems like it ought to work, like the drug they've developed to go after the fibrillary tangles in the brain of Alzheimer's patients. So it all looked really good in theory, but then when they actually gave the drug, the findings weren't impressive. So which is more important to you? Saying, well, it makes sense that this drug should be working, or it didn't work? Like, which is more important to a patient? It didn't work. So in theory, going after volume seemed like a perfectly good idea in terms of healthcare costs, but it looks like, based on those studies, that it would be more fruitful in the United States to go after the prices of things. Furthermore, if you talk to a patient, if you survey patients, find out what percentage of them think that prices are too high in the United States, that charges are too high in the United States, versus how many of them would say that they themselves or anyone they know had an unnecessary medical procedure. And I guarantee they'll all say the same thing. People know that prices are too high in the United States. This should not be an epiphany for anyone. You know what I mean? It's like, duh. So anyway, so that's kind of what found. And this is Willie Sutton. Anybody know who Willie Sutton was? From the first half of the 20th century. He was a bank robber. And when he was going to prison one time, this is him on the left again, he was asked, well, why do you rob banks? I left out the word you. Why do you rob banks? And he said, well, that's where the money is. They have a lot more money than any of the other stores in town, so that's where I go. But it turns out in the United States, all the mainstream policy strategies are not based on going after price. They're more based on going after volume. And so we have about just a few minutes left. So I just want to get first into more of what the Democratic Party tends to support, the notion that the greedy doctor is doing too many procedures, and if we just go after that, we'll control healthcare costs. So there's something called small area variations research. Groundbreaking study in 1973 did a county by county analysis of Vermont, and then repeated in Maine, and the number of elective procedures. So in other words, you don't necessarily have to have a hernia operation if it's not incarcerated or strangulated. So it varied. Prostatectomy, well, you could try some other procedure, a drug to control your prostatic related symptoms. So there was a lot of variation there. Hysterectomy, what if a woman has a lot of bleeding, extreme amount of bleeding? You know, you could find there's especially for younger women, you can find medications that control it. You know, find another way. And so there's a whole lot of variation between the number of procedures for, say, per women of reproductive age in one county compared to the county with the lowest frequency. Now, the obvious thing for you to ask is, are the women in the low frequency county happy about this? Are their symptoms controlled? And note, by the way, notice D&C has a tremendous variation. This is also a procedure dealing usually with bleeding, inappropriate bleeding. Not every time, but a lot of the time. And then obviously varicose veins is there's a lot of variation too. So the procedure that did not have much variation was aortic aneurysm. That tends to be more constant. Appendectomy was more constant. So some procedures, a patient comes in with a, you know, perforated stomach, you know, ruptured peptic ulcer, and they're perforated, and they're, you know, peritonitis, and you know, happens and sets in. Obviously, they're going to get surgery if they possibly can. So there's very little county to county variation. That's not just random statistical fluctuation. So what the suggestion was, the assumption by the researchers was that the lower number represented high value care and the higher number represented greed or incompetence. It's difficult to test that assumption, but that was kind of the main, and led to the quality equation, the value equation. The value was the quality of care you got. So they did want to measure quality, make sure the women in the low frequency counties were in fact having adequate quality care, and you compare that to the cost. So that's sort of the theoretical quality equation. How to measure cost is very easy. You just count the dollars. Measuring quality, that's a whole other affair. And measuring quality is problematic. It can be done structurally. You know, do you have the fire extinguishers on every floor in your hospital? Process measures, have all your employees, do they know how to use the fire extinguisher? Do they know how to respond to a cardiac arrest? A lot of that is through chart review, usually fairly easy data to get a hold of. So you could say, well, I'm sorry, I want to look at mortality. I mean, that really matters. But is a hospital's mortality rate going to be statistically significant, for one thing? And secondly, if somebody comes into the hospital and they don't want to, and they're elderly and they kind of want to opt out and they ask to be put on comfort care, does that reflect poor quality care? So the circumstances really start to make, and sometimes the statistical significance start to become real problems. Another really big issue. So anyway, here's what, so some things are easy to measure. If you're in primary care, did your patients, women between 50 and 70, get their mammogram as they're supposed to? And now 40 to 50 as well. Following preventive care, measuring preventive care is really easy. Did it get done or didn't it? And for things that there are clinical guidelines, that's a little muddier because patients have this habit of being very individual. You could look at sentinel events, a procedure-related infection, and that may have issues with statistical significance. But all those things together don't add up to more than 1%. So if somebody comes to their primary care doctor and their shoulder hurts, or they say their elbow hurts, does that mean if the doctor doesn't order an x-ray or does order an x-ray, is that good or bad care? Well, it's tough. If a child has that elbow thing that kids get where they dislocate their radius, very common in 2-year-olds. A nursemaid's elbow, I think it's anyway. You can fix it. It doesn't even need an X-ray. And literally, a child can walk out using their elbow. So, saying an X-ray or an orthopedic referral is not necessarily better or worse care. It depends on the situation. Very difficult to judge. But I'm going to finish up with Caldwell's law. Caldwell's law is, you must know about Caldwell's law. When a complex bureaucracy, like any hospital, is faced with a high stakes measurement, like what Medicare is measuring, the hospital will ignore all their other important activities, particularly ones related to quality of care, that are not being measured in favor of optimizing the high stakes measure. They'll cheat, they'll fudge, but at the very least, they'll give up all their other quality work because this is really going to hurt them at their bottom line. So I've seen this so many times during my professional life, I can't even begin to tell you. So anyway, that's the first part of talking about cost control.